All right. Hello and welcome to ImmunoLogic, the show where immune breakthroughs meet clinical logic, turning cutting-edge discoveries into practical, patient-focused action. And I'm Dr. Joe Fraietta, and I'm excited for two reasons. First, this is our very first full episode. Second, I've actually dropped 8 pounds since episode 0. I've joined the rest of the country on the GLP-1 agonist wave. So I hope it shows on camera. We'll know next week. But before we'll see. Or Noah, you'll have to do more editing. But before we bring on our special guest, let me introduce our new co-host, Dr. Janna Minehart, and she's a clinical oncology fellow, actually at the University of Pennsylvania, who also happens to do research in my lab. And despite that, she still agreed to join me on the show. So, Janna, thanks for coming along for the ride.
I'm so excited to be here.
We'll see what you say at the end. All right, let's get into it. So today we're honored truly to speak with, a man who's basically a legend in lymphoma research, Dr. Stephen Schuster. And I have to pull up your credentials. You're the Robert and Margarita Louis Dreyfus Professor in Chronic Lymphocytic Leukemia and Lymphoma Clinical Care, and an attending physician in the Department of Medicine's Division of Hematology and Oncology at the Hospital of the University of Pennsylvania. You're the director of the Lymphoma Translational Research Program at Penn's Abramson Cancer Center, and really, if I may say, a world-renowned pioneer in CAR T-cell therapy. So for our guests, if you've read anything about lymphoma in the last 20 years, you've probably seen his name, or at least you've cited his papers. The man has been practicing medicine for over 40 years. He's authored more than 200 peer-reviewed articles, and he runs a ridiculous number of clinical trials. So basically, if you need proof that human beings can do more in a single lifetime than binge watch Netflix, look no further. It's the one, the only Dr. Schuster. So Dr. Schuster, welcome to ImmunoLogic, and thanks for taking a break really from saving the world to chat with us. And I mean that sincerely.
Thanks for the invitation, Joe. The honor's really mine. I'll accept man, legendary and world-renowned. Well, that can be debated. But in any
Not
event,
to us.
I'm happy to answer any questions that you might have. And
Great, wonderful.
Go ahead and pick my brain, what's left of it.
Okay. Oh, come on. Janna, do you want me to start or do you want to dive in? It's up to you.
Why don't you start us off?
Okay, so let's address the big question straight away. I hear from Janna and others, all of you clinical folks, that there's a push to remove chemotherapy from lymphoma regimens. And I know this is a separate thing, Steve, but potentially even from standard lymphodepletion before adoptive T-cell therapy. So how close are we to seeing that become standard practice, or is it still a pipe dream and a long shot?
No, I think in part that's true, and I'll give you some details. Obviously, in aggressive lymphomas, we don't want to throw the baby out with the bathwater. So I've cured more patients with combinations of chemotherapy with immunotherapy, anti-CD20 antibodies over the last decades than I care to count. And I don't think that I see that changing in the area of aggressive or large B-cell lymphomas in the near future. With regard to small B-cell lymphomas, and these include the indolent lymphomas like follicular lymphoma, small lymphocytic CLL, and marginal zone, I see chemotherapy disappearing. In my own practice, it's already disappeared. I'll give you an example. In chronic lymphocytic leukemia, up until 2014, immunochemotherapy was pretty much the standard frontline therapy that patients received when they met IWCLL criteria for treatment. Ibrutinib was approved in January of that year, and for some subsets, but nevertheless, we managed to implement it as first-line therapy. And subsequently, randomized trials have shown that overall survival is prolonged in patients when they start with BTK inhibition as their primary therapy, as opposed to getting immunochemotherapy. And that's even with a crossover design in the study. So clearly now the world has accepted in that small B-cell lymphoma that chemotherapy is not frontline therapy. And indeed, even in second and later lines, we've moved to BCL2 inhibitors with CD20 antibodies, and even CAR T in third and later line therapies. And the FDA has now conditionally approved CAR T for that. So clearly in that group of lymphomas, in my practice, it's been since 2014, but in the world's practice, it's now chemotherapy has been eliminated. I see that happening in follicular lymphoma as well. I mean, I generally, regardless of, unless I suspect a large cell transformation, I generally start with monotherapy with an anti-CD20 antibody, serotherapy, immunologic serotherapy as frontline therapy. And you can hit a home run by using that approach, particularly if you get a partial response and repeat and treat to complete response. I'm satisfied with those results and can avoid chemotherapy in some patients. And when you start talking about second line and later lines, then chemotherapy, the question of chemotherapy comes up. Marginal zone is what splenic marginal zone lymphoma, excuse me. For example, frontline therapy is rituximab monotherapy. So it's anti-CD20 monoclonal antibody monotherapy. And I see that moving into frontline across the board for marginal zones, or at least a trial of that before going to chemotherapy. And of course, in localized marginal zones, subtypes of extranodal marginal zone that are outside non-splenic types, regional radiotherapy in addition is a great option for those patients. So I think in large B-cell, I'm talking about B-cell lymphomas now. Large B-cell lymphomas, probably a third of them are large B-cell, and chemotherapy will remain part of the frontline therapy. But for the other 2/3 of B-cell lymphomas, I'm seeing chemotherapy disappear from frontline therapy. And ultimately, I think immunotherapy will be the approaches that are used in those diseases. Now, for second line and later large B-cell lymphomas, immunotherapy with CAR T is now standard of care. Okay. And as you mentioned, that does involve some chemotherapy for lymphodepletion.
Right.
And the question in my mind is whether in lymphomas, lymphodepletion is really necessary. As you know more than I do, the lymphodepletion facilitates expansion and engraftment of the engineered CAR T cells so that they can have adequate numbers and for efficacy. However, lymphoma patients oftentimes have had a multitude of therapies, at least by the time I see them, and have reduced lymphocyte numbers and as you've shown in some of your work, reduced lymphocyte fitness or ability to continue proliferation, meaning a lot of them have a terminal differentiated or so-called exhausted phenotype. So it may be possible in patients to eliminate lymphodepletion. It's not been adequately studied, although on some of our trials, one in particular with the IL-18 armored CAR, the first patient was treated without any lymphodepletion per protocol and had a very successful result. And given that we've not adequately studied the necessity for lymphodepletion in B-cell lymphomas, I did write a study which is now funded, and we hope to be active soon in follicular lymphoma using CAR T without lymphodepletion. And these would be patients in third or later line that meet an FDA-approved indication for follicular lymphoma. And there is a crossover so that if there's not a response, they can get lymphodepletion and be treated that way. But I suspect we're going to find that we can get away in a significant number of patients without lymphodepletion. And quite frankly, I like when chemotherapy is unnecessary, it should be avoided. Anything that damages DNA is potentially negative in my opinion. And in fact,
and that trial you're talking about is that's autologous T cells. Is that correct?
Autologous. Yep, that's autologous, and it's also with the armored IL-18 anti-CD19 CAR. So, Janna, the fact is maybe the reason we had that one successful result, and maybe we'll see success in this because of the armoring. That I don't know. And that'll be the criticism. People will say, well, you got away without lymphodepletion because these CARs make their own cytokines so they can keep themselves happy. And that may be the case. if that's the case, then I would prefer armored cars to chemotherapy because, as I said, DNA damage is something that I'd like to avoid, and it's hard to use alkylating agent-based chemotherapy without inflicting some DNA damage in tissues, and particularly hematopoietic tissues.
Right.
In fact, we're seeing secondary myeloid leukemias and myelodysplasia in survivors of lymphoma that have had CAR T, and these malignancies have the genetic stigmata of alkylating agent-based injury, making me think it's more from prior chemotherapy than from the CAR T cells themselves. And
commonly with chip-related mutations.
Right, and exactly. And we found that some of these cancers, the patients have had antecedent clonal hematopoiesis of undetermined significance, so-called chips, where they already have a couple of genetic hits in their cells, and the chemotherapy comes along and provides the final step in development of malignancy. So I think it'd be beneficial if we could eliminate chemotherapy for patients, particularly those that have had prior chemotherapy, and particularly those that have chips, which, as you know, increases with age. Just living leads to DNA damage.
Right, absolutely. What an answer.
Sorry, I'm long-winded.
No,
I have to warn you.
No, it's great.
It's
great. It's great. I know, but it's, I always learn something when we run into each other, even on the elevator, and you're so inspiring to all of us here at Penn and beyond. So, well, here's a good one for you. So I'd like to talk about less hyped, but potentially impactful ideas. And Steve, I know you have no shortage of those, because we're always running into each other and chatting about, what we could do in the lab. And, I feel like here, especially with what we do, we're chasing, the latest, for example, gene editing breakthroughs. But let me say this, sometimes straightforward approaches get overlooked.
Absolutely.
So that's what I wanted to ask you about. And what's a research area in particular that you think we've overlooked, but that, frankly, deserves more attention?
Okay, so lots of ideas. I've always, it's really my ADD comes through, and the ideas happen much more frequently than the completed projects. But I've got a couple little projects that have been that I'm particularly excited about. One that I'm hoping by the end of this month, I'm able to have a preliminary report and submit this study to Lugano. Basically, and this is not something that happened overnight. I mean, working on it for 8 years on and off. But we've used machine learning to look at pre-treatment scans from our patients that went on to CAR T therapy. Now, why did I pick CAR T therapy? Not because I'm at Penn, it's because I ran CAR T cell studies and I had loads of scans from patients that I had long-term outcome data from. And we taught the machine, we showed them scans from successes and failures, and repeatedly over 800 cases, and the machine came up with an algorithm that is able to predict, when we looked at a blinded set with 85% accuracy, whether a patient's going to be alive and in remission in a year after CAR T. And as you know, if you're in remission for a year after CAR T for a large B-cell lymphoma, which is what these patients had, the prognosis is excellent, and very few patients relapse subsequent to a year. So what I'm doing right now this month is one of the large pharmaceutical companies has given me scans from one of their registrational trials that have been completely blinded, so I don't know the outcomes. And we're reading them now, and then I'll submit to them my results. And if we end up with a similar accuracy that we had when we studied our in-house cases, we'll have another test that can help to prognosticate success in terms of picking our patients. Now, don't ask me what the computer sees, but we did get it down, though. Initially, we were doing multiple lymph nodes, and we got it down to all that we have to do is do one cross-sectional. We just need the images from one cross-section of one lesion, one lymph node that's a lesion, and that the computer can make its decision based on that. So I think this is the beginning of
Incredible.
artificial intelligence.
Yeah.
I wonder how
being-
how that will end up being operationalized in terms of your clinical decision making, whether it
Well-
might change your decisions about bridging therapies or
That's a really good question, Janna. These scans that we looked at were done post-bridging prior to CAR T. Okay, so this might be a study that if and again, I'm saying 85%, but maybe that doesn't mean that those that didn't pass the algorithm are not going to have a good outcome. 15%, it was not predictive, and then and so it's not 100%, but it might say that this patient is somebody who is likely to have less than an optimal result of the year. So perhaps they should be on a study. For example, we know that, and now this has been shown now for, well, we haven't published it, but we have the data and it will be published in large cell lymphoma as well as in CLL, which has been published, using ibrutinib after CAR T cells, BTK inhibition after CAR T cells with ibrutinib has been shown to improve results. And actually, someone else presented similar data at ASH this year as well. So, but we have data for large cell lymphoma. We also have data for follicular lymphoma showing this, which we presented in abstract form. And the large cell stuff a couple of years ago, we presented in abstract form as well. So it may be that there's a subset of patients that we want to do an add-on in a clinical trial kind of setting to see if we can change outcome. The other thing, as you know, we're running a trial where we're using simultaneously bispecific antibodies directed at CD20, which is a different antigen from the CAR T cells, which target CD19. And maybe these are patients that in the future will want to do that. And of course, what we'll do if we validate our initial findings is we'll start studying our patients going on to all these studies to see if any add-ons change the outcome in patients that the computer otherwise was telling us would have a poor outcome. So I think it's a tool to try to improve for all the patients the overall outcome with therapy. And again, I don't know what the basis that the computer uses for selecting this, but there's 11 dimensions that are in the algorithm that the computer reads that look like white noise if you try to look at them on the computer screen. And somehow, amidst all that electron activity, it picks up signals that predict outcome. It's got to be, there has to be some biologic underpinnings to it, but I haven't the foggiest.
It's incredible because go ahead, sorry.
No, we're also looking at it now before RCHOP, standard chemotherapy for large cell, to see if it's predictive there. Because again, it may be that it's therapy specific. Maybe this only relates to CAR T cells. There's just so many questions to answer. But I think now that the algorithm's worked out, and if we validate it, we like I said, one section of one lymph node, we can do this very, very quickly, add this onto a lot of studies and get a lot of information.
Yeah,
so
and it's not invasive. It's great because, as you know, we've been looking at the T cell compartment and we've done some predictive modeling in the lab. The problem is that the predictive signature is over 50 features, right? And it's not just from one, say, flow cytometry panel. There are a whole lot during the whole, sort of vein to vein process. You have to integrate all of those features. And it's like, not every center will be able to do that, right? So that's what the beauty of this is, really.
That's why
really exciting.
So nice to be where we are at Penn, because we have access to all this enormous amount of data from all the trials that we've run, that you can actually take as many variables as you want and put them in. And this is actually where I think artificial intelligence is helpful. When you start getting into more dimensions than you can visualize in your mind, that's when you need the computer's help. And the computer is always going to need us to ask the questions, I think, at least now.
I hope so.
That may change too. But,
Joe, talking about the kind of predicting responses to cellular therapies and thinking about T cell fitness, it's always kind of been surprising to me that there isn't a stronger signature or a simpler way of assessing CAR T cell fitness or
Well, I
predicting
wanted you to
patient
do that,
outcomes.
Janna. You know that. That was another
One of
project.
our many project ideas that we've talked about. Yeah.
So I just came back from Korea, where I actually gave 5 different presentations. And I met in Busan a microbiologist who runs the quantiferin gold assay there. And we were interested, you and I, in using the control arm of that assay to look at lymphocyte fitness in a fast, simple way, looking at interferon gamma production using the control portion of the quantiferin gold assay. So basically, they're going to start running that on all their CAR patients. They've actually, at that center, they've done 12 CARs in the last year and start gathering data, and we'll start doing it before our patients as well. And that way, what we can do is just look at the control arm, gamma interferon production, and see if we can draw any preliminary conclusions that way, and then study it in more detail. So you're right. Yeah, lymphocyte count is kind of a crude estimate. It sort of tells you how much the patient has been exposed to prior therapies, which definitely correlates with a bad outcome or poor lymphocyte fitness. But yeah, a fast assay like gamma interferon production, a functional assay rather than an immunophenotypic assay, is really what I'd like to see. And again, that may factor in, why is that? What could you do about it if somebody has terrible T-cell fitness? Do you not treat them? No, we now have AlloCAR. So, AlloCAR, we at Penn have had very good results with the first 7 patients, and these are engineered so that the anti-CD19 CAR is inserted into the T-cell receptor alpha locus gene, so that you don't have an alloreactive T-cell receptor on the cells. Instead, you have your CD9 directed CAR receptor, and you can give fit lymphocytes to people, and it seems to work quite well. And the toxicity seems to be acceptable. So it may be if we start looking at patients' fitness and making a decision there whether to do allogeneic or autologous CAR T cells. So I mean, there's so many potential options these days that the more information we could get to accurately predict outcome, the more we can develop strategies that will result in the end for better outcomes for patients. And it's not one size doesn't fit all. I mean, we'll be customizing therapy based on what the computer tells us about the prognosis, what the lymphocyte assays tell us, et cetera. And we have plenty of tools to work with these days.
Yeah,
so
absolutely.
That was one of the projects. The other project that I haven't started, but it's on the drawing board, and I've discussed it with some potential pharmaceutical sponsors, is to make a universal T cell from young fit people that we can combine with bispecific antibodies. It seems as though, and we just published a paper in Blood Advances which supports that lymphodepletion prior to or strongly suggests lymphodepletion prior to CAR T impacts outcome after bispecifics, and because they also rely on T cell fitness for outcome, and the data support that. So it may be that in those patients who aren't responding, we give them doses of fit lymphocytes from allogeneic donors and can convert them to responders that way. So so far, getting a little bit of interest from industry for that concept. Obviously, it's a big project, and I have to do a little bit more salesmanship, but I think we'll get there.
Yeah, it's all
You're
about
a pretty convincing guy. I believe in you.
Definitely. Me too. And so could I bring up the topic of persistence? So what's your opinion on whether or not, especially since we're talking about the allo products, can we retreat if we don't see, persistence? What is that like in lymphoma? I actually have no idea.
Well, the allo products don't persist. Mm-hmm. Okay. Usually by a month or so, they're gone. But, we're only studying large cell lymphoma for the large B cell lymphoma for the allo CAR product. And so persistence, I think, is not particularly important in large B cell lymphoma. Why do I say that? Well, there is some evidence for this. Number one, the CD28-driven CARs, like axicabtagene ciloleucel, don't persist, and yet achieve remissions that are as durable as what we see with the 4-1BB CARs, which do persist. And and there's lots of questions, again, as to, well, is persistence important in other areas? Well, it's clearly important in pediatric ALL,
Yes.
okay? Because when we see loss of persistence in pediatric ALL, the patients relapse and B cells recover. I have a feeling, this is just a feeling at this point, based on anecdotal observations made in the clinic, that in CLL, persistence is important, and perhaps in follicular. So it may be in the small B cell lymphomas, persistence becomes more important, but not necessarily in large B cell lymphoma. Just the way we can use rituximab plus CHOP in large B cell lymphoma and get a complete remission that's durable for a long, long time, even forever. But that doesn't work in the small B cell lymphomas. So we talk about different diseases, different natural histories. The interesting thing that is another project, and actually we've gathered the samples and we're going to do some work with this as well. There's unlike pediatric ALL, we see B cell recovery in patients when they go into remission after CD19-directed CAR T cell therapy, despite persistence of the 4-1BB CARs. About 80% of the patients have persistence of the 4-1BB CARs at 2 years in our studies. How is it that these B cells manage to recover when there's an anti-B cell CAR that's still present, in the bone marrow? I think if you look at, I think what we need to do, we know that there's, a lot of alternative splicing that can happen with the CD19 RNA. So what we're going to do is we've collected the patients that have B cell recovery, and we're sequencing their CD19 RNA in those patients to see whether or not there's alternative splicing that gets rid of the epitope that the CAR cell recognizes. Because we're just trying to, alternatively, maybe there's some kind of tolerance that develops. I don't know, but the first step, I think, is to make sure that the CD19 that's coming back is of the same structure, has the same epitopes as the CD19 that was present on the malignant cells. So
definitely,
we are going to look at that, or this year we should have those results.
That would be fascinating if under that selective pressure something was happening to the
So I think it may be important for some diseases persistence. I think ALL, probably CLL, and maybe even follicular. Why do I say maybe follicular? Because I think if you look at the long-term 3-year follow-up studies with the CD22 CARs versus the 4-1BB CAR that we use, it looks like, and these are published data, it looks to me like there's not a plateau in the progression-free survival curve for the CD28 CARs. So it's kind of interesting. And again, it's 3-year survival data that I'm comparing, so we have to wait a couple more years to be sure, because it's not even clear that there's a plateau for the 4-1BB, although I think there may be. So it may be, and that would be evidence that persistence may be important for that. So we may be selecting our CAR T cell products based on the disease.
Right. Yeah, absolutely.
It would be interesting too. I feel like retreatment with CAR is not discussed very frequently, but I could imagine a scenario in like what you're discussing, someone who relapses late with follicular post-CAR with a CD28 co-stimulatory domain, whether if they had additional cells remaining, especially whether retreatment would be appropriate.
Well, in the early days, when we were treating aggressive lymphomas, large B cell lymphomas, and we tried retreatment, we were unsuccessful. But the data that Jacob has with the IL-8, Jacob Svoboda has, my partner, for the IL-18 CAR, suggests that actually you can get those patients who failed the commercially available CARs to respond to that. So it may be that we use an armored CAR in that situation, and it looks like it's particularly useful in the patients that have had the prior CD28 CAR. Why that is, I'm not clear. Hopefully, Joe and you will give me some ideas about why that might be. But I think that there will be CAR strategies for those patients. It may be using armored CARs. Maybe the patients we treated was just too soon. In the data for bispecifics that we published, the response rates to bispecifics really take off at 9 months after CAR T. So if we were trying to treat patients, with a second product that was manufactured prior to 9 months, there's probably inadequate lymphocyte function, or recovery to make a good product. If you use the same product, I'm not sure, but it clearly using the same product in the past, within 6 months after CAR failure, did not really work well. So we need to learn more about it. But I'm optimistic that we'll be using, based on Jacob's data and a larger trial that's been running now that we don't have results for yet, that we may, for patients that have been exposed to commercially available CARs, that using a next-gen CAR, the IL-18 armored CAR, may be the strategy that we use for those patients.
Yeah, so maybe I've always wondered about this. I think there's good evidence, in glioblastoma where they sort of serially resect, but that whole concept, or this whole concept of adaptive resistance, and maybe the armor is, reshaping the tumor microenvironment in some way, right, in lymphoma, and that's why it's working.
That may be it. You bring up a good point, though, Joe. Tumor bulk clearly impacts outcome with CAR T-cell therapy. So patients that have a partial response prior to going to CAR T-cell have an excellent outcome, and those that have progressive disease don't respond. And those that have stable disease are somewhere in between. Okay, the ones that have stable disease are about 30% success rate. The ones that have a partial response are 45-50% success rate, and those that have progressive disease between screening and infusion on the pre-lymphodepletion scan all fail. So getting control of the disease, reducing the tumor volume, may be the way to do it. Whether you do it with successive or fractionated CAR T-cell treatments is one idea. Maybe we now have more effective so-called bridging therapies that we can use to control disease prior to lymphodepletion, like bispecifics. We're running a clinical trial right now where we're using bispecifics as a bridge, and also kind of to mobilize activated T cells for product manufacturing, to see what kind of outcomes we get using that approach. So, but I think if we just get more patients to at least partially respond to therapy and have reduction in tumor volume prior to going to CAR T, I call it disease control. It doesn't have to be a complete response. It just can't be progressive disease, at least stable disease. So stable disease, partial response, complete response to bridging. Disease control is mandatory, and whether you do it with successive CAR treatments or using an alternative bridge with one of the newer bispecifics, are things that need to be studied. But it may be that these patients who fail with progressive disease might benefit from a fractionated CAR with the same original product. I've seen patients who have failed, although they have shrinkage of their tumors after the first CAR T-cell treatment, they go on within 3 months and fail. And they're the patients you wonder if, while the tumor is down, prior to regrowing, if you gave them another dose at that time, you might do better. So
I've always found it hard to parse that data of those patients with progressive disease at time of lymphodepletion, whether, how much are you seeing the kind of stoichiometry problem of the tumor bulk versus just the disease aggressiveness, and especially with the kind of heterogeneity of bridging therapies.
I see what you're getting at. In general, tumor bulk correlates with tumor aggressiveness, but correlation is not causation, as you well know. And there are highly aggressive tumors that can be small volume and proliferate rapidly. And to be honest with you, I think that's exactly why we've not had success in Burkitt lymphoma with our current CAR T-cell approaches. So I think that you can have and I've had patients on the original CAR T-cell trials that had highly aggressive double hit lymphomas that were controlled but failed. therapy. So, and I'm thinking of very particular cases. So yeah, it's a matter of disease control, and we can use reduction in tumor volume by imaging as a way of doing that. But there's other parameters that you have to look at. Those highly proliferative tumors almost always have an increased serum LDH. And if you look at response rates and outcome with CAR T cell and serum LDH, there's it's almost like a dose response curve. So if your LDH is normal, you've got a great response rate. You're up 50% or a little above. If your LDH is less than 2 times the upper limit of normal, but greater than 1 times the upper limit of normal, you're in between. If your LDH is above 2 times the upper limit of normal, you do poorly. So I wish we had a better assay for proliferation, like a soluble Ki-67 measurement, or like years ago we were looking at doing thymidine uptake by PET imaging and looking at proliferation via DNA synthesis by PET imaging. That may be another approach, but there is going to be some. There's going to be heterogeneity in response, but I think clearly if you get shrinkage of the tumor and the LDH normalizes, you've got control. And that's going to be your best scenario. If you have shrinkage and the LDH is down somewhat but above the upper limit of normal, you may get somewhere. The LDH is still sky high. My prediction is, regardless of shrinkage, you're going to have a problem with outcome, because the LDH we did a multivariable analysis, and this is all published. I'm not just talking off the top of my head. We did a multivariable analysis that shows that it's independent of everything. Okay, bulk, number of we looked at a bunch. We looked at a multitude of cytokines on this multiplex assay. We looked at that was one of the 2 things that fell out as being independent in a multivariable analysis. And I'll bet you it's not independent of bulk, because bulk relates to tumor aggressiveness. So maybe we should just be looking at LDH control. I don't know.
Maybe it's simpler. Yeah. Sometimes a simple answer is the right one. Well, thanks, Steve, for all of those amazing insights. It's been really fascinating, as always, to learn from you. And with that, we'll wrap up our very first inaugural episode of ImmunoLogic. Thanks to everyone for listening, and we're looking forward to having you join us again to learn more about basic science and clinical oncology.